I don't know if I can handle this level of technology. So I'm Ezra Lyon. I'm one of the family medicine doctors at Daily Care in Wapaka. I've been there for about 2.5 years. And I'm kind of the point person for trying to get more medications for opioid use disorder and other addiction treatment in the medical system, at least in Theta Care. So I had put together this presentation really as a starting off point, because I guess I'm assuming that people have some lived experience with some of the things that we'll talk about. And so I'd like as much as possible for this to be, hey, stop, that doesn't fit with what I know about this, or just an ability to ask questions. So this is really intended to be a jumping off point rather than I stand in front of you guys and lecture. I passed around folders and in FAQ, which has been just expanding over the 2 years that we've been doing this in Wapaka. The folder has all the materials except one, because the print shop didn't print it, that I hand out to new patients when they're starting buprenorphine. And so I'll go through some of those materials, but I think it's nice to have a look at what we give people. And then the FAQ kind of goes through buprenorphine in specific. It was written for the clinic staff when they rolled it out 2 years ago, and just been expanding since. So I really like this quote from Dr. Chinazo Cunningham. She was one of the speakers at the American Society of Addiction Medicine last year. And that we just have to keep people alive, and then we can talk about everything else. We're at the stage in the pandemic or epidemic of overdoses where overdose prevention, I think, is the most important thing. I'm sure everyone in this room has lost someone or multiple people to substance use disorders, and that's what it looks like for substance use to be the leading cause of death in young people in this country. So at this point, there's a lot of argument out there about what's the perfect solution, what's the ideal recovery, for me, what matters is keeping people alive. And let's see if this works. Nope.
2 fingers.
2 fingers.
And then put it
on the board.
Yeah, there you go.
There. This isn't new to anyone else, right? We're in the middle of an overdose epidemic. Leading cause of death in young people, was already horrible and then worsened a lot during the pandemic. So from last year, the 12-month period ending in October of 2021, there were 105 overdose deaths over the country. And it helps me to put that in perspective, both with other medical conditions that I'm treating, because I'm primarily speaking to medical audiences, but also, how many people is that? So we're looking at a number of overdose deaths that's like the entire population of Green Bay over the course of a year. And then just thinking about, we at some point will have breast cancer or colon cancer awareness months and lung cancer awareness. 105 overdose deaths is more deaths from overdose than from breast cancer and colon cancer combined. But I don't see a whole ton of pink ribbons for overdose. This is from the International Overdose Awareness Day event in Madison. This quilt apparently is huge. I haven't seen it. I just love the picture. Just to remind us that, again, not in this audience, but sometimes in medical audiences, that when you're thinking about people who are suffering from an use disorder, they're someone's daughter, they're someone's son, they're someone's parent. Like, it isn't, people are people. This is that rise in overdoses, specifically looking at opioids. Starting back in the early 2000s, we saw that rise in overdoses driven by prescription, oxycodone, hydromorphone, hydrocodone. And then as prescription started to be cut down and heroin became more accessible, we saw a rise in heroin overdoses, which we're still seeing a lot of heroin overdoses starting about 2010, and then 2013, the huge rise driven by fentanyl. Went way through. Sneak preview. Okay. This is what it looks like in Wisconsin. Same idea. Same national trends reflected here. Prescriptions, then heroin, then all of that plus fentanyl. So we really have three different overdose epidemics happening all on top of each other. We're still seeing lots of people die of prescription overdoses. We're still seeing lots of people die of heroin overdoses. And then we've added on top of that all the people dying from fentanyl. I wanted to take a...
You can say next, and I'll move it next.
No,
if you
it's
want.
fine.
No,
I'll do it.
All right, all right.
I'll figure it out. I wanted to take a minute and go through what does it mean, I'm going to use the term opioid use disorder a fair bit. What does it mean to have an opioid use disorder? So let me take the diagnostic criteria away, and I want to just go around the room and, when you think of what the medical term a use disorder means, what does that bring up to you? You guys have probably talked about this already during this class. Do you want to just go around?
Using too much?
Too much.
Dependent,
And what do you mean by dependent?
like physically, emotionally, mentally dependent on chemicals like fentanyl, especially. Or even Suboxone, methadone, you just become dependent. You
Uh-huh.
can't do anything without it.
Yep. Can't do anything without.
Life has become unmanageable.
Life unmanageable. Anyone else? So we've got physical things, anything about life being unmanageable. Like, in what ways does it become unmanageable?
With opiates, I can't do a fucking thing without it.
Yep.
Well,
It becomes your energy.
yeah, I mean, yeah.
You can't sleep, you can't eat, you can't shower.
It drives every aspect of life.
Yeah, that's all you think about.
Couldn't go to work, couldn't not go to work, couldn't wake up, couldn't go to sleep, couldn't fun, couldn't eat.
You start to do criminal activity.
I keep thinking trauma. I don't know.
Yeah.
Trauma. And why do you think trauma when you think a use disorder? Like what parts of it, of a use disorder, bring up
That you're
trauma?
causing yourself and then other people as well.
So that damage to yourself and others.
Controls you.
Uh-huh. So it controls you.
And then the physical damage.
What else can you say about it?
Yeah, liver,
Yeah.
MRSA, Pepsi.
Pepsi.
Uh-huh.
Yeah. Loss of morals.
Loss of weight.
Yeah.
So, sorry, I heard loss of relationship, loss of morals, loss of weight. Okay.
And the secondary effect would be the allocation of resources, law enforcement, medical aid.
Sure. So we're thinking about like a particular individual and whether they would have a use disorder diagnosis. But yeah, consequences to others. This is a good list. And so when people, a group of psychiatrists got together about 10 years ago and said, well, what are these criteria? Like if I'm encountering someone, how do I know they have a use disorder? They came up with 11 criteria that encompass a lot of this. And that's what I want to show you guys on the next page. So when you say that someone has a use disorder, we're looking over at least a 12-month period at various aspects of this. So one of those is this loss of control. right? You're taking more opioids than you want to. You're trying to cut back, but you can't. And then it's controlling your life. You're spending a lot of time acquiring opioids, recovering from opioids. And craving, strong desire, that's all part of it. And then the effects that it has on people's life, right? So we talked about damage to relationships, damage to yourself and others, criminal activity or incarceration, problems functioning. That's this recurrent opioid use resulting in a failure to fulfill the obligations. How does it affect work? How does it affect school? How does it affect things at home? And then continued use despite those problems, right? Relationships are going to shit, but you still can't do anything without it. And so you can't help that the relationship is going to shit because you've lost that control over the disease. And then these kind of repeat. Important social, occupational, recreational activities given up or reduced. Again, really that loss of control. Recurrent use in situations where you know it's hazardous. So, having suffered or knowing other people who suffer physical damage and still knowing that that's happening, and I would add overdose to this. And that's kind of redundant with the next one. Knowledge of having a persistent or recurrent physical or psychological problem, psychological, caused by it. And then the last thing are these physically dependent things. So tolerance, what does tolerance mean to people?
More.
Exactly. So your body gets used to a substance. This doesn't happen with every medication. I take lisinopril for blood pressure. I've been on the same dose for years. It still works the same. But for a lot of medications or substances, whatever we want to call them, as our body gets exposed to them, it responds to being exposed by decreasing the number of receptors that we have for that substance. And so it takes more and more and more to get that same effect that we see. So that's tolerance. And then withdrawal. How would we define withdrawal?
Hell.
Hell.
Yeah.
Sick. So things that are happening to us when we lack that substance. So I don't really know what I'm talking about. My use here is caffeine, but I get caffeine withdrawal headaches. So it's the same idea. Goes out of your system and you start suffering physical consequences because of that. These two last ones are just weird, just as a side note. If you're prescribed a medication, it doesn't count towards a use disorder. So if I see someone who has been on oxycodone for their back pain for years, they don't necessarily have a use disorder. Even if they stopped taking it tomorrow, they would have the exact same withdrawal symptoms that anyone else who has long-term opioids.
So how would recreational heroin use fall into there without adverse effects? Because let's face it, I mean, I'm part of that whatever percentage that can't do a fucking thing. But there's a lot of people that presumably could use, let's just say clean heroin, recreationally in this country.
Yeah, that's a great question. So let's say paint a scenario, and then let's try to run that scenario, that person, through this, and see would they qualify as having a use disorder.
Dr. Carl Hart wrote a book about it. He's a professor at Columbia University, uses heroin recreationally every now and then, and does not consider himself a drug addict, is able to write books, maintain his duties at school and home, has children, raises his children, respected in the community, and is an IV injector, heroin user a couple of times a week.
And so he probably, a couple times a month, he probably isn't getting tolerance. A couple times a month, he's probably not experiencing withdrawal. If he is, using a clear, good supply of heroin and using around other people, using safe injection techniques, yeah, he may not have a heroin use disorder. So you need
Normal people can do it. It's not, the drug is not the demon.
It's the cells.
reason, so they don't.
And the social context. So
Yes.
you're sitting with a lot of being able to have a supply of heroin that you can depend on so that it isn't physically hazardous, having the knowledge to use it in a safe way, that's a very rare thing. So yes, but most of the time when people are using opioids in this context, the context of using here within a drug supply that people can't trust, usually that means that you're meeting at least some of these criteria. 2 or more criteria are a use disorder. 4 to 5 goes into that moderate use. So when I talk to someone who's been incarcerated, because I get this question from colleagues like, well, do you go through and you ask all these questions of someone? And I say, no. If I'm sitting down with someone, they're like, yeah, I started using at 19, and I was incarcerated at 21, and I lost my kids, and my boyfriend died of endocarditis, and I overdosed twice. Like, that's a severe use disorder. I don't need to, I may I can ask more questions. But you don't have to like sit down and ask every single one of these. But yeah, absolutely. Substance use does not mean a use disorder. They are not the same.
I guess I get a little bit quieter about my own question there because, I think about the psychological reasons to use in the first place, then if you are a recreational user, you would like not out, you would like the effects and how that doesn't really translate to a use disorder either.
That's correct.
Yeah, that's
Yep.
kind of
And I think this is an easier question to ask if we pull heroin out and replace it with, say, marijuana. Because there is a cannabis use disorder. But I see a lot of patients who are using cannabis and don't really have any of this going on. Because just to be clear, for most use disorders, you just pull opioid out of here and you insert whatever back in. Or, this is Wisconsin, pull opioid out and insert alcohol.
also insert methamphetamine.
Or insert methamphetamine. Yep. So we've got a lot of people who have alcohol use, but are still able to fulfill major obligations at work, school, or home, are drinking alcohol without major physical consequences. Now, we've got a ton of people in the state with an alcohol use disorder as well, but we've got a lot more people who are drinking alcohol in a way that, well, probably isn't the safest thing, also doesn't rise to the level of a use disorder.
The other thing is I find interesting is that legal trouble or anything like that's not on that list. So just because you're, even if you are, or I guess if you're not, legal trouble really shouldn't play into it, right? The fact that, somebody comes to you and says, I use heroin and I got caught with some shit and now I want to go through treatment and stuff, may not have opioid use disorder.
They may not. It gets tough because this obligations at work, school, and home. Well, if you're starting to get in legal trouble, or you've persistent use despite getting into legal trouble, that's the social context in which we're living,
Yeah.
in which use is bringing on legal trouble. So, I don't know if I answered your question
Yeah,
there,
you did.
but hard
You
to
did.
separate it. So
Yeah.
if you're incarcerated and therefore you can't take care of your kids, well, that's part of the use disorder. But yes, nothing about this says legal or illegal. Okay. So, why do I care so much about medical treatment of opioid use disorder and other substance use disorders? Part of that is just there really are not many people, for how bad of a problem this is, we are not getting medication out to many people. So this is from Dr. Gupta, who's with the White House Office of Drug Control Policy, wrote an editorial this past fall, and he estimates that of the almost 277 million people in the country who are over 12, it's somewhere between 3 and 8 million of them meet criteria for an opioid use disorder. And of those, less than 300,000 receive medications. Slightly more are receiving some kind of behavioral-based treatment.
Why do you think that is?
Stigma.
stigma, but could it also be that in a correctional setting where most of those people end up, they're not afforded the luxury of being able to get the treatment that they need?
And then I think that gets back to stigma too. So when I am thinking about opioid use disorder or other use disorders, I play a little substitution game in my head. And I say, what if we swap opioid use disorder out with diabetes? You know, you go into jail and someone says, oh, I'm going to stop your diabetes medication. Well, that happens. That stuff happens too. Carceral settings are not good settings for treatment of chronic medical conditions for a lot of reasons. But no one is out there arguing, oh, people should not be getting insulin while they're in jail.
Right?
So that's a thought exercise I play a lot. So we have 3 FDA-approved medications in various forms for opioid use disorder. So methadone has been around since the 1970s. It's very tightly controlled. So right now, methadone for opioid use disorder can only be prescribed at an opioid treatment program, so-called methadone clinic, of which we have some in the area, but nothing within 45 miles of this. I guess 45 miles.
From Appleton.
Appleton, okay, nothing within 40 miles.
There you go.
I don't know. I live in Amherst, so I'm a little bit further that way. So, and what methadone is an opioid full agonist. So there's a couple slides further on, but you have your opioid receptors that are sitting on the surfaces of your cells. Methadone binds to those receptors in exactly the same way that heroin does, that fentanyl does. So it binds to and activates the receptors well. Buprenorphine is a partial agonist. So it both activates the receptor, but it doesn't quite have the same effect at the receptor that something like methadone, fentanyl, oxycodone does. The naloxone that's in with it, so like Suboxone is a combination of buprenorphine and naloxone, is not thought to be active. Maybe some of it is absorbed from the stomach, but it's really there to help prevent people from injecting it. And it doesn't work at that.
It does not work.
Nope.
Yeah, I was just gonna say, for someone who's been exposed to Suboxone almost since day one, 2001, I can tell you that it didn't take us but maybe 2 years of being able to use it.
No.
Not only to inject either the tablets or the twin tabs, but to totally defeat the naloxone purpose.
The buprenorphine's a lot longer acting than the naloxone is.
I mean, I could go at that point, I know they said it would throw you precipitated withdrawals and all that stuff. I have literally shot a tab of Suboxone on my way to buy heroin and vice versa within an hour of each other, and none of that happened.
Because those high concentrations of buprenorphine, and we see this when we're treating precipitated withdrawal, overcome that withdrawal state
Right.
for the most part. And yes, the naloxone is basically useless. However, Wisconsin Medicaid doesn't agree, and so really I can only prescribe the combination product.
Right.
And then we have naltrexone, or Vivitrol. Naltrexone, you can think of it as a long-acting form of Narcan. So it's a complete opioid blocker. It is in both oral, there are tablets of it, and injections. The intramuscular injection, or Vivitrol, the monthly Vivitrol shots, are the only ones that have been shown to have effectiveness against opioid use disorder. There's a, now,
From a
there are,
craving standpoint or from a preventing binding to the receptor standpoint?
from a craving stick, from a like track people and say at a month on treatment, how many people are in treatment. So basically oral naltrexone, people stop taking it and then it's useless. Generally, the same thing happens with Vivitrol. So some people find that it's a good long-term medication for them, but not a lot. So and this, I put this in the pamphlet. It's the pamphlet that we stole from UIC, going through each of those 3 different medications. And on the bottom, it gives us how many people stay in treatment at a year. With methadone, it's about 75 out of 100 people stay in treatment after a year. With buprenorphine, Suboxone, it's about the same, 60 to 90%. It's a harder medication to start, so less people are in treatment after a month, but that kind of catches up over the course of the year. With naltrexone, it's about 10 to 20 people out of 100 are in treatment after a year. Well, 75 versus 15 is a big difference to me. And it's that difference that drives why naltrexone is has never been shown to be effective at preventing overdose. And I have a slide later that shows kind of what happens. And this, again, probably have personal experience with this. People do okay with cravings while they're on the shot, and then they stop. And then they have no tolerance, and they overdose and they die. And that's what we see in the literature too. So there are people for whom Vivitrol is a good medication. They can stay on it for years. It's a minority of patients.
Can I ask you about Subutex also?
Subutex is buprenorphine.
Yeah.
So Subutex is just buprenorphine with the naloxone not in it.
Normal naloxone whatsoever. And that's not the standard for prescribing now? I mean, it's not...
Wisconsin Medicaid doesn't cover it for opioid use disorder. So I basically don't have it. I can only use it for pregnant women.
Can I ask you why?
I don't know.
There's
There's no good data. I mean, yes, you're exactly right. There's no reason. And it's on, when I think about advocacy, that would be a good thing. So this is just, yeah.
On naltrexone, my primary care physician prescribed me with that to reduce cravings for alcohol.
Yes,
That is an appropriate use.
a very appropriate use. So naltrexone, because it's an opioid blocker, and so it blocks the exogenous opioids, so opioids that you're getting from outside. So if someone were to use heroin when they're on naltrexone, like a month into naltrexone, yes, you can overcome it. But for a lot of people, that blocking is helpful and helps prevent the cravings and helps prevent overdose when you're using it. It also blocks somewhat the endogenous opioids, so the opioids that our brains make, right? We didn't make receptors in our brain for heroin. We make receptors in our brain for the opioids that our brain is producing. And some of those opioids, so things like endorphins, some of those opioids are involved in our reward pathways. So like when I'm eating too much, or when someone has cravings for alcohol, or when someone has a gambling problem, those same opioids, that same reward circuit that Aaron probably talked about yesterday, gets activated, that dopamine surge. Naltrexone, by blocking the feedback that comes with those opioids, seems to work for other use disorders as well, and it's our first go-to medication for alcohol.
Can I ask you if there's been any efficacy for that for like nicotine cigarettes or anything like that?
Doesn't seem to work for cigarettes. I don't know why. So, yeah, it's been studied, but doesn't work. But it's money.
Anything with cravings for methamphetamine or anything
Oh.
like that? Or, I know.
Yeah, there is a study that came out 2 years ago that showed that the combination of Vivitrol, so naltrexone, the long-acting monthly naltrexone plus bupropion, Wellbutrin, the medication that we use for a lot of things, smoking cessation, depression, being the top things. That combination was somewhat successful. So so in that study, they took people who were long-term users of methamphetamines, and it was a good study. It had like almost 1,000 people. It was blinded, so people didn't know if they were getting the injections or not, or the pills or not. Of every 100 people in that study, if they got the placebo, if they got the sugar injection, the sugar pill, about 5 of them were able to be off methamphetamine at the end of the study, which I think was, I'm sorry, I didn't pull that information. And on the active part, the people who got Vivitrol plus bupropion, about 15 out of 100. Well, 15 out of 100 stinks compared to the 60, 70, 80% that we're seeing for methadone and buprenorphine in terms of retention and treatment. But hey, it's way better than 5. So that is something that I would use based on that study. Unfortunately, a lot of people are using, a lot of people use both amphetamines and opioids. And so I can't prescribe someone both buprenorphine and naltrexone, right? The naltrexone will block the buprenorphine.
Can I ask you, and then I promise
Yeah.
I will.
No, this is great.
Well, this is what we're talking about. We're talking
Yeah.
about a healthier, healthier people in the community. Okay?
Yeah.
Methamphetamine is a big part of that. There's a shit ton of.
Absolutely.
Methamphetamine. Can you talk a little bit about how do they call it, off prescribing
Yeah.
for vigil for
Yeah.
methamphetamine maintenance?
Modafinil, which is Provigil. There's probably 15 medications that have been tried. None of them in big studies. We need research funding. We need some big studies for meth use disorder. Many of them have been studied only in the context of cocaine use, which is not nearly as strong of a dopamine release as meth. Modafinil is something that if I was treating a patient, I would consider it for their meth use disorder. Mirtazapine, which is an atypical antidepressant, which sometimes helps with sleep or weight gain, is another thing that I would use off-label. I would go more to that combination of intramuscular naltrexone and bupropion if someone was not using other opioids. Yeah, there are a lot of medications that can be used off-label. There are no, so we've talked about these being the free prescription, FDA-approved medications for opioid use disorder. We have 0 medications for stimulant, FDA-approved medications for stimulant use disorder. Yeah.
Just say something about
Oh, I was talking about mirtazapine. I don't know, mirtazapine's, so olanzapine is an atypical antipsychotic. So it's a different kind of medication than mirtazapine, which is like an atypical antidepressant. I don't know if the antipsychotics have been studied for. So antipsychotics being like olanzapine, which is Zyprexa, quetiapine, which is Seroquel. They've been studied for meth use disorder. I think that the studies have been, they haven't been encouraging. So they don't make my 5 things that I would try. Yeah, good question. Yeah, but I wish we had a methadone or buprenorphine for meth use disorder. That would be amazing. Okay, so naltrexone completely blocks the receptor. Buprenorphine partially blocks it and partially activates it, and methadone just is a full agonist. Binds with it. Buprenorphine. So what does it mean that you've got this partial agonist? And what kind of effect does that mean? Well, I think the most important thing, and the reason that it's the safest, or it's much safer than heroin, much safer than methadone, is because as you take more of it, you hit this ceiling effect at relatively low doses. So if someone goes from, someone doubles and doubles and doubles and doubles their dose of heroin, at some point you're going to overcome their tolerance and they're going to die, right? Breathing's going to slow down, people are going to overdose, people are going to die. Well, buprenorphine, you hit a ceiling. So if someone's taking 8 milligrams and then 16, 32, 64, 128, they're unlikely to see much at all of an effect with taking larger doses.
extreme.
Oh, did I just hit?
You got it right there.
Yeah.
What did I do now?
Yeah. Hit the button.
Wait. Oh. It's okay, we're good. Uh-oh, now you're editing it.
Am I editing it?
No, you're fine. You were.
This is terrible, terrible.
It's a great technology.
Yes, that's what I said.
Okay. Okay. So, and it's that ceiling effect, which means that makes it a safer medication.
Can I ask you, I don't mean to ask.
No, keep asking. This is great.
So I know, so with buprenorphine having a ceiling effect, limit to respiratory depression, people have, I talk about the combination again with fentanyl being in and methamphetamine, sleep problems, prescribing benzodiazepine short term with buprenorphine, better, worse.
Benzos increase the risk of overdose substantially with opioids. So benzos are like the one thing that I worry about a lot. It doesn't mean I would never do it in my patient population and with my patients, but the overdoses that we do see with buprenorphine, I don't want to say all, because if I say all, I'll be wrong, but most are in combination with benzos. So yeah, mixing it with other sedating medications is not generally a good idea. But yeah, it's difficult because it's not a drop-in replacement for fentanyl or methadone, or so it's often there's often like when I've taken people who are on methadone and they want to switch to buprenorphine because their life doesn't support them driving to Oshkosh or Appleton every day. That's an adjustment. They're not the same medication.
And methadone is also a full agonist.
Methadone is a full agonist.
Yeah,
Yep.
right.
Methadone is a very long-acting full agonist. Okay, this is just to state the obvious for people in the room, but methadone is not an option for many reasons for many people here. It's a good medication. It's a life-saving medication. It's as effective as buprenorphine. The only reason I'm not talking about it is because we're here in Waukaka, and our closest methadone or opioid treatment programs are Oshkosh and Appleton. So, yes, if someone has 3 hours of their day every day that they can spend treating their opioid use disorder, an opioid treatment program is a great option. But it's a much better option if you live there.
And the reason we don't have one, I mean, so the clinic is a special clinic, special license. and
Yeah,
An
there's-
option to get one here.
That's a great question. I would like to see that a lot of those regulations go away, because if I were to open a methadone clinic here, it would take all of my resources. Whereas, I mean, just like all the regulations you have to do, the requirements that you have to start people on daily dosing and then you have to step them up slowly, like none of that is whatever medically studied. It's not clear that any of that is necessary. And when opioid treatment programs went to more take-home dosing during the pandemic, they didn't see a lot of overdoses. People are I mean, I'm sure there was more diversion, but we didn't see a whole lot of people overdosing because of take-home dosing. So, yeah, if the regulation, I mean, if I could prescribe it out of primary care, I would do it. I just can't.
Interesting that the methadone clinic model in this country is almost a microcosm of a test case for a legalized opiate scenario. You know, same type of go to the bank, get what you gotta get. I mean, it's models that are working in countries like Portugal, Switzerland, overseas now. Similar. I'm not gonna go on there right now.
Okay, that's okay. No, these are good things, because it's important to think like, what's the best that we can do within the constraints that we have right now?
Mhm.
And then how can we push those constraints? Because again, what matters is keeping people from overdosing.
Agreed.
People lived experience have been through this, but with acute use, right, the first time that you use something, you feel normal, and then you feel good. But pretty quickly, right, tolerance builds up. And so people are using to just feel normal, right? We talked about that. The goal of medications for opioid use disorder is to try to keep you in the normal state. So, risk reduction, reduce the risk of overdose. We'll go through the frequently asked questions at the end, because I think does answer a lot of things. So I talked about one reason why buprenorphine is my preferred medication. We talked about the fairly low rates of retention of people in treatment on naltrexone and the difficulty in getting people to treatment with methadone. This is one of now many studies that show that the reduction in death when someone's on methadone or buprenorphine, it reduces death by about 50% from overdose. So this study is a good example. This looked at everyone in Massachusetts who was seen with an overdose. So they overdosed, they were seen in an emergency room, they got entered into the statewide database, and then they went back and looked and said, well, what happened to those people in the next year? And then, were they prescribed any of these medications? Because all the medications are tracked, right? When I prescribe a medication, it goes into a database, and so they pulled out that information and said, well, what happened? So this is time 0, this is when the person overdosed, and this is a year later. And here is how many people died from anything, right? If they had a heart attack, if they had endocarditis, they had liver failure. So not being on any medication, those people who were sick enough to be in the emergency room after an overdose, about 5% of them died in that next year. So it took 100 people, 5 of them died. Naltrexone, again, no reduction in overdose death, and it was seen in this. It was seen in the initial studies. This validates that. The people who are on naltrexone, either in this was including the month before when they died. So it was like either you were on no medication. I'm sorry. So now you count it as naltrexone if you were on naltrexone in the 2 months prior to your death. Buprenorphine and methadone. Methadone performed a little better. That's a common theme. It's a little better medication. Both lead to about 2.5% to 2% of people dying. That's a huge difference. I don't have anything else in medicine that if I say, you 100 people, we're going to watch you over the next year, and if we do nothing, 5 of you will die, and if we do something, 2 of you will die. And so the way that, so I need to only treat 50 people over the course of a year to prevent 1 death. So when I think about like my patient panel and how I'm feeling treating, sometimes I do the mental exercise of like, well, I know the number needed to treat is about 50 to 100 to prevent a death in a year. And that's a consistent theme, that we see this, like you treat about 50 to 100 people over the course of a year with methadone or buprenorphine and you prevent 1 death. With higher risk patients, this is even more pronounced, right? Just a general rule that the higher risk people are of something, if you treat the people who are the highest risk, you see the largest benefit. So super high risk people, right? So people released from incarceration are super high risk of overdose. So we know that the risk of dying from an overdose in those 2 weeks leaving incarceration is 120-fold the risk of dying in the general population. Because people are incarcerated, they lose tolerance, they come out, they use, they overdose, they die. So Rhode Island, because it's a tiny state and it's the size of Dane County, decided, and it has 2 jails and 2 prisons, they decided, well, we're just going to treat everyone. So we're going to do universal screening for opioid use disorder. We're going to offer medications for opioid use disorder, any one of the 3 that people want when leaving incarceration. And they ended up, so 3,000 people were released from incarceration over the course of a year. They started 300 of them on medications. And they saw a decrease in the number of people who died after leaving incarceration from 14% of them dying of an overdose. 14% of the people dying of an overdose had been recently incarcerated. They cut that down to 6% of the people who were recently incarcerated overdosed. And so what they calculated from that, and that was a reasonable number of people, they had 180 overdose deaths in the state. So they cut that down to 157, and much of that was reducing this 26 to 9. So they calculated, well, we treated 300 people. We think that 15 of them probably were prevented from having an overdose. So we only needed to treat 11 people leaving jail to prevent a single overdose death. Not overdose death. So I put this in here because I really do think when we think about this, and just in general, like patients who are not as far gone in the use disorder aren't going to have as much benefit from treatment. They still have that benefit from treatment, but because they're less likely to overdose or get Hep C or get MRSA or have endocarditis, the medical benefit of treating is lower. It doesn't mean that people don't need treatment, but it also means that when you're seeing someone as a peer recovery coach, and they're like really tenuous, those are the people who need the most help. Because they're the people who are the easiest to like, oh, they no-showed from my clinic, I'm gonna like send them a notice saying they can't come back to clinic. I deal with this bullshit all the time. Sorry, I shouldn't swear. I deal with that stuff all the time. But it's those patients that are the highest risk that have the highest benefit from treatment. I'm sorry, I feel like I'm up on my soapbox. Is this okay? Is this useful information? Okay, sorry, I went back. No. I will figure this out. Okay, so buprenorphine. We've talked a little bit about this, so it comes in basically two main formulations for opioid use disorder treatment. There are sublingual or films or tablets that you dissolve, are intended to be dissolved under the tongue. Suboxone, Zubsolv, which is kind of minty. Subutex, which is just the buprenorphine component, but again, Wisconsin Medicaid doesn't cover it. And then there are monthly injections, Sublocade, which form a hard lump under the skin. So we now have those in clinic here in Wapaka.
We don't?
We do,
Or you-
we do. Yeah.
Is that like once a month?
It's once a month. Yeah, it forms a hard lump under the skin. It seems to work as well. Well, is this safe? Yeah, I mean, for all the reasons that we've talked about, it is a pretty safe medication. Yes, people die from it. So this is a study in the UK. For 1 million prescriptions written with buprenorphine, there were 22 deaths. And they compared that directly. In the UK, you can write methadone prescriptions. And like it's like an eighth the death rate as people overdosing on methadone. Let's go through that. Thank you at the end. So as a peer recovery coach, I think it's important to get people in for treatment and to think about this as part of their kind of life-saving approach. I have put together a directory, oh shoot, I forgot to put the slide in, of clinics in the broader area that prescribe buprenorphine with contact information, with hours of operations. Do they offer things like the subcutaneous injection? Do they treat Hep C? Do they treat pregnant women? Do they? So I've been working on that, so that should be a good resource. Oh, I did put this slide in. The red dots here plus, no, sorry. I'm gonna screw this up. There's a fair amount of treatment in the area. We're not a desert. So the blue things here are clinics in the data care system that treat opioid use disorder. Ignore that one, that's a mistake. I thought our provider up there was treating, she's not. But Wapaka, Wild Rose, Princeton, Markesan, Shawano, kind of, Appleton, Oshkosh, and then all the other things. Some of these are like where the emergency rooms in my system are, but there's the tribal clinic up in Kashina. There's a number of places, Ascension, Aurora, in the Fox Valley area, Mosaic, Partnership, and then the opioid treatment programs. This is what we're doing in Wapaka and Wild Rose. We've got now 8 doctors and 7 doctors, 1 PA on board. And since 2020, when we were treating about 15 patients in that year, we're up closer to 140 patients now, 130 patients. Now, of course, people cycle through, so we lose people from treatment. In our clinic, this is the way it works. So there's a unified phone number that one of the RNs answers the phone. They triage, are you withdrawing? What's going on? They schedule an intake visit with a provider. That provider makes a decision. Do you start buprenorphine in the office or do you do it at home? And then they do continuing visits. Most people who talk to us, but not all, because we're making that decision, is this an appropriate treatment, are leave on Suboxone, and of course we prescribe Narcan. And it's going to be over the counter. What a great change. We try to connect people to peer recovery. We try to connect people to behavioral health services. We have clinical substance abuse counselor, behavioral health, mental health treatment. And most of the other clinics have something like that, where they've got a group of people. What does home induction work like? Well, you gotta be in moderate withdrawal. That's one of the things that makes it easier to start methadone. You can just start methadone. Someone could use heroin a minute before they walk into a methadone clinic. Well, they might not start you that day. But regardless, you don't have to go into withdrawal first. But with buprenorphine, you need to go in withdrawal because it has that partial blocking effect. So if you use if you use a smaller dose, not a huge injected dose, right after you've used a full opioid agonist, methadone, heroin, oxycodone, fentanyl, it can put you into withdrawal. So we wait until people are in moderate withdrawal and then start buprenorphine. I put in the packet here what I usually give people if I see them in clinic, which is this gentle self-start protocol, which is really straightforward. It's not a difficult medication for 80% of people, 90% of people to start. The thing that everyone worries about is precipitated withdrawal. Does anyone experience or know about precipitated withdrawal? So it's awful. So basically what happens is this is this woman's opioid receptors. If they're all full of, say, fentanyl, and you give yourself buprenorphine is really good at binding to the opioid receptor. And so it'll bind to the opioid receptor, it'll kick off the fentanyl, and you've got that maximum effect from the fentanyl because it produces more of that opioid mu agonist effect. So when you're going from that kind of full throttle to half throttle, and you're going from a maximum effect of the opioid to kind of a moderate effect of the opioid. That's enough of a change if it happens quickly that it can put you into withdrawal. So that's the main thing I worry about when I'm starting someone on buprenorphine. If they've had horrible problems before, we'll sometimes do a different strategy, like start with little tiny doses and wean people onto it. I use that very commonly when someone's on methadone. They just continue their methadone dose, and I slip in little tiny bits of buprenorphine and slowly increase, so that rather than going in 20 minutes from all their receptors have methadone on them to all the receptors have buprenorphine on them, we're taking a week to go from all the receptors of methadone to all the receptors of buprenorphine. It's still not fun, but it's much more tolerated. Does anyone have questions about this? This is probably the hardest biochemically for.
Just so you know, I tried to do that with I see Amy Menton.
Hey, Amy.
Yeah, and I was going to the methadone clinic. I was on it for 3 months.
Yeah.
And we switched to Suboxone. And she wanted me to do exactly what you're saying, take the methadone.
Didn't work.
No, it did. And so I was honest with the methadone people, and they cut me completely out and said, nope, can't do it. She wrote them everything. What to do. So I went into withdrawal. Yep. You just gotta be sneaky with them, apparently.
Yeah, I wish we all worked together.
Yeah.
Not surprisingly with everything we went through, this is supported by the national organizations, both on the law enforcement side, the medical side, the governmental side. And then this is where I've ended the talk for medical things. And I don't care what people self-identify as and what words people use, but when I'm treating someone or when someone's answering the phone at my clinic, they better not call people drug addicts or say that they're have a dirty urine. They should be using the person-centered language. People with a substance use disorder, urine that was positive for marijuana, not a dirty urine. All urine's dirty, right? Doesn't matter if it, or if someone returns to use, they return to use. I did have a few slides on alcohol, but I wanted to stop here and basically ask for questions about opioid disorder. Yeah.
Especially with buprenorphine. So, have you ever, what I found out there, so my wife and I were on it, my ex-husband actually, was on it for a long time. And we had a doctor talk about, is it harder, have you found it's harder for females to get off of buprenorphine or Suboxone when they're trying to come off of it than it was for males? I had heard something about density of fat cells or something like that.
Yeah, I don't think there's any good evidence about that. But yes, maybe. I really have no evidence. No evidence on that.
And then the other thing, you tapering off Suboxone, I can just tell you, the last time I did it, I've done it a lot, but the last time I did it, it was like, get down to like one, and that shelf getting off the one was just a fucking bitch. And then, what was weird about it was, I get down to that, and then like 5 days later, I'd have to have another one. And then, it was weird, I was fine, and then like 10 days later, I'd have to do another one. And it was like over, withdrawals would kick in like that.
Yep.
Yeah, if you could speak to that a little bit.
It's a long-acting medication. It itself sticks in your system 24, a day to a day and a half, and then it's active metabolite. So what our body turns it into, which still has effect in the body, lasts for a couple more days beyond that. So I've heard different things. I haven't personally experienced this. I've heard different things. I've had patients tell me it wasn't, and patients tell me it was worse. Yeah. Situational maybe. And then yes, there's almost certainly some that's in fat reserves in the body, and so that's kind of slowly leaking out as well. This, like, the lower the dose that you get to, the harder it is to stop, is something we see with a lot of medications. I see that a lot with benzos too, where like that last half or quarter or eighth of a milligram of lorazepam is the absolute hardest to get off of. Some people have gone to using those Sublocade injections, so subcutaneous injections, in a way to get away from withdrawal, because in some ways they self-taper, because you've got this hard lump under the skin. Go ahead and put that slide in here. I think so. You've got a hard lump under the skin that slowly, very slowly, is releasing the medication. It's hard to see there at the bottom, and I wish I put one of the other slides, but the way the Sublocade works, because you think of it like it's a shell, kind of a hard lump that's releasing buprenorphine. When on day one that you release it, well, it solidifies and you actually get a lot that just comes off the surface as it's solidifying. But then as it gets smaller and smaller, you've got a smaller and smaller surface area to release the buprenorphine from. But even months later, you've still got a little tiny bit of it that's still releasing some. So in some ways, it self-tapers. So people have done that, where they'll do the Sublocade injections. They'll go from doing them every month to doing them every other month or every third month. Or people will take that dose and so it comes in 300 and 100 milligram doses. They'll just say, well, next one's going to be 75 milligrams, and they measure how much is there, and they squeeze out 25 milligrams onto a piece of Kleenex and throw it away, and then give the 75 milligrams. So that's another thing that we found to be useful for tapering and withdrawal.
And I know we didn't talk that much about this Zubsolv. What's the difference there? I mean, I've only taken that one a couple of times, a lot, but
I've got patients, so buprenorphine, for anyone who hasn't taken it, which includes me, it tastes like shit, right? They're awful. You have to dissolve them under your tongue. If you swallow buprenorphine, only about 10% of it gets absorbed. So they really are not, they have to be dissolved to be effective. And none of the products taste good, and all of them are associated with a risk of tooth decay as well. The difference in every different formulation, people tolerate a little differently because of how quickly it's dissolving in the mouth, because of its taste, because of the other stuff they put in the tablet with the buprenorphine. I've got patients who tolerate Zubsolv but haven't tolerated anything else. So that's when I go to it. It's also covered by Wisconsin Medicaid.
So prescribing, let's just say somebody comes in, we all know that there's fentanyl and methamphetamine. How do you handle that from like a med-assisted? So we have somebody come to us, out there, and they're looking for that. You get them. How do you handle that?
So like they've got some fentanyl in their system because they're using meth.
Yeah.
So if they're looking for help, I would consider starting them on buprenorphine. It doesn't work for meth use disorder, unfortunately. It's been studied. But will it help them from overdosing from fentanyl? That's contaminating their meth? Yes. And then sometimes I think that, or for some of my patients actually, where meth was the primary thing, but they were intentionally using heroin on the side as well, or what they thought was heroin. It's been helpful to kind of get in the door, to kind of feel like, no, this isn't like I have a team behind me. This part of my use disorder is stabilized and might be, like I've had people tell me it's helped with their cravings for meth, and I don't know what that, again, that's not what the literature, like that's not what the studies show. But I don't know if that's just the like, I'm telling someone about what I'm doing, I have someone to be accountable to, I don't know. Because if someone comes and they come to me with the heroin and a meth use problem, and we're able to treat the heroin use and they're still using meth, like that's a victory for me. That's not.
That's what probably depends on how honest they are with you.
Yep. Because most people who come to me, like they've had many years of, I'm sorry, I'm being profane being shit on by the medical community.
No,
So people aren't expecting help for the most part, and aren't expecting respect, or aren't expecting, So I tell people, be as honest as you can.
So I'm gonna give you another hypothetical. I mean, when somebody comes in like that, it's pretty subjective when you're deciding what dose to put them on as far as Suboxone, right? So you say, I know people who've been on, 24 plus, 28 milligrams a day, or 4 milligrams a day, or whatever. And I get what you're saying. You want to get as many people on this because it lowers the overdose risk. But I want to play devil's advocate.
Please do.
Just listen to say, So a guy comes in and he's using methamphetamine, he gets put on Suboxone. I can tell you flat out that I've used Suboxone like that as currency on the street to pay for my methamphetamine when I was coming up,
Yeah.
And I worry about, med-assisted treatment, adding to and creating or enhancing the so on so forth black market.
Agreed.
Yeah.
So I worry about that too. So if someone came to me and said, I'm just using meth, I wouldn't prescribe them Suboxone. I mean, I wouldn't prescribe them Suboxone on the off chance that that reduces the risk of them dying of a fentanyl overdose. Maybe I'm doing the wrong thing there, but I do worry about diversion. In our clinic, we use the same things we use to try to prevent diversion in other opioids. So we can have people come in for pill counts or a random urine drug screen. Many people are involved with community corrections and are doing urine drug screens on a regular basis. If I know that someone's diverting, the hard cases for me are when someone's diverting and using, and continuing to use the buprenorphine. That's someone that I would try to push towards Sublocade. The other thing that gives me a little bit of relief is that again, this is studies, so I'm curious to hear what people's experience has been, that many people who are buying Sublocade, no one's buying Sublocade off the street. People are buying Suboxone off the street are often using it to manage their withdrawals. And so I've definitely seen that with a lot of my own patients who are coming to me no longer in this use disorder because they were self-treating with Suboxone that they obtained either from a friend or were purchasing from someone. Those are the easiest patients for me. It's like, okay, great, let's make that legal. Yes, some people are using Suboxone to get high, but it's not the majority. Most people are using it either as again, what I've heard from my patients is they're either using it as a filler between their ability to get something else, or they're using it to treat their use disorder in pretty much the same way that I would treat their use disorder. And so yes, I worry about that. I bear legal responsibility for prescriptions that are sent out in my name. I'm less worried about that than when I sign an oxycodone prescription.
And then the only other thing I would say is, and I guess it's not really the drug portion of this, but the harm reduction thing is big for me. Clean needle program around here. If you could speak to that a little bit.
I'd love to have a clean needle program around here. For my patients, needles are not considered drug paraphernalia in Wisconsin. So if someone tells me that they're using, I will prescribe them needles and syringes.
That's great to know.
Because again, they're not considered drug paraphernalia. I can prescribe them. If insurance might say, most people aren't paying insurance for it. I know that Stratton's will allow people to, I think, buy needles. I'd love to have something a little more formal at our pharmacy. It's not something that I've really explored much.
I know that Walgreens in New London, you didn't need a prescription, you could go right through the drive-through window and buy them.
Yeah, because I'd rather, I treat Hep C in clinic. I probably treated 10% of my patients with an opioid use disorder. And that's thankfully because we're now at the place with Hep C treatment that a lot of people are already coming to be having already been treated, which is great. But yeah, less people dying of liver problems in 20, 30 years. Other harm reduction, co-prescribing naloxone is just the standard of care. We're trying to get fentanyl test strips. There's fentanyl in everything, so I'm wondering whether that will be as effective as it probably would have been a couple of years ago. But I'm surprised when I don't see fentanyl in someone's urine if they're using off the street, regardless of what they think they're using. But it's still not everything here. So maybe those are helpful. We have them through public health. We're going to distribute them in clinic, and I'm trying to get them in the ED and in the clinic as well. We have in the clinic through public health, you can ask for Narcan, and we have kits that we give out for free. Narcan's free in our InstaMeds machine in the ED. It's a prescription, which is annoying. It's available for as low as $1 from the outpatient pharmacy, which we reopened, the old Shopco pharmacy that's inside TakeCare and Wapaka. So if you go in, you say, I need 10 Narcan prescriptions, they'll fill 10 Narcan prescriptions for you. Yeah. So those are the things that we're trying to do around harm reduction. It's clearly not enough. I love the idea of a Narcan vending machine. I hope that public health applies for it because it's one of the, there's a grant from the state that will do that. Yeah, good questions.
I just want to say, I think, you said before you don't want to cuss or anything. I think but your sincerity and the depth that you have with this, and I think it shows that you give a shit. I just wanted to say that because, I pummeled you pretty good.
That's okay.
I get that, but I can tell just by talking to you that your heart is in this and in the right spot. And I don't think that it should go without saying. So I appreciate that.
It's not just me. I don't know. I'm not going to get back, but you said that you see Dr. Mandeville. We've got 7 other colleagues in our. We're at this point right now in Wapaka where we have more prescribers of buprenorphine in our clinic in Wapaka than in the whole rest of the Theta care system combined. Because it's not a hard medication to prescribe. Again, what other things am I going to prescribe that if I prescribe to 50 people, I'm saving a life over a year? I can send a lot of cholesterol medication to not get to that. So I think it's a compelling story once people get past the stigma. And get past the I don't want those people in my clinic. It's well, what does that even mean? Right. One, you already have people with opioid use disorder in your clinic, you just don't know about it. And 2, if you don't want people in your clinic, but yet we're supposed to be here to serve the community, what does that mean?
Yeah, if you don't want those people, let's fix those people.
Right.
Or give them the tools to help themselves. That's the other sheet I have passed out is this frequently asked questions. It goes through a lot of things that I've heard. So I don't know if people just want to page through that and see if they have anything else any other questions they have, and then I'll give back control to Michael because I've probably taken too much of your time already.
Can you touch a little bit on, because we had this conversation, but your work in like building the zero barrier clinic environment and how you're trying to do that, and how you're trying to work with EER to kind of help at some point get there.
Yeah. So, my vision for treatment of opioid use disorder is that whatever medical facility you walk into, it should be the same. So if you walk into the ED and you say, I'm struggling with an opioid use disorder, or I'm withdrawing, or I've overdosed, that you're being treated with the standard of care, which at this point in the outpatient setting is buprenorphine, if that's what the patient wants and all of that. We have a protocol right now in the ED to do that. I haven't had a whole ton of kind of takers among the ED prescribers, but it's something that I'm continuing to work on. I have another couple meetings next week with the ED about that. The goal for us is to have this be the standard of care across all of our Theta Care EDs. It already is across the Ascension EDs, at least in the Milwaukee, Racine area. I don't know about St. Elizabeth's, but I know it's their plan eventually. And then the goal is also with people with an opioid use disorder who are hospitalized for some reason, which is often this stuff, right? MRSA, endocarditis, that they are also treated with standard of care. One of the cases that stood out for me in the last year, we had someone who had been in prolonged recovery, like 5 years, from their heroin use disorder, and then had a return to use that had been going on for like 2 years, and got a bloodstream infection, and got endocarditis, an infection of the heart, and needed to be on antibiotics for long term. So he was treated in Appleton for 2 weeks, and then he came out to Wapaka to be like kind of at a nursing home stay in the hospital to continue receiving antibiotics. And like a week into that, one of my colleagues who isn't one of our Suboxone prescribers in the clinic is like, this guy's got an opioid use disorder. And yeah, of course, like that was why he was in the hospital. Well, he's having trouble with pain control, and they were worried about him using the oxycodone. Why don't I talk to one of my colleagues? And so they got one of my other colleagues, Dr. Sedlak, to talk to him like two days later, and we got him started on Suboxone in the hospital. And so he went out and he had a visit 3 days later with the prescriber back in Appleton. But people shouldn't need to come from Appleton to Wapaka to get the standard of care. That doesn't seem right. I mean, I'm happy for it to be like that. It gives me some Wapaka pride, but yeah. I don't know if that answered your question, Michael.
My other question is, so like just from personal experience last night in the emergency department. So I was at church carrying one of our littles up the stairs, and I slipped, and because he tried to jump out of my arms, I couldn't brace my fall or anything, and my knee went right down on the cement and just split it. And so I go into the emergency room, and like I have an X-ray to make sure nothing's broken, and I was afraid to ask like what has worked for me in the past with serious injuries since recovering from substance use disorder. And like I'm afraid to even ask, because then they think, oh, and I know that's not a controlled medication, but it's like I didn't even know what to do, and then they were like really attentive at first, and then went and then came back and like took an X-ray, put a wrap around my knee, sent me out with some Tylenol, and that's okay. But I hear I just feel it in there, like when they start looking at charts, like I know this is something. I'm like, can you just treat this, like make sure it's not. That's how I approach it now, because I don't want them to think that I'm trying to seek pain meds, but I do want to know if my knee's broken or not. And actually, they sent me out without even telling me if I had any fractures or anything. And the girl at the front desk said, "So did the X-rays come out okay? No breaks or anything?" And I said, "I honestly, they didn't tell me." And, so I'm like, how do we help change that? Like, because we do get hurt,
Right.
right?
Right.
And there would even be situations where it's appropriate to treat with probably some narcotics.
Absolutely.
One of them, but
Right.
like, I
Yeah.
was in that situation, maybe 2 years ago, I fell and broke my toxic,
Yep.
yeah,
Tailbone.
tailbone,
Yep.
that's what I'm looking for. And I couldn't do it without the medication, so I had like a really difficult conversation with my primary, and like we just worked it out how we would like,
Yeah.
have a risk plan put in place, and I was okay, and that was okay.
Yeah.
Surprisingly, I thought it was gonna be hell, because I was terrified of it, but it wasn't.
Yeah.
Because I think we had all that stuff in place.
Yeah.
Imagine that it actually worked when you take it as prescribed. Would have never occurred to me in a million years. So, yeah,
Yeah.
how
How
do
did-
peer support help shift that needle so that when anybody in this room goes to the ER, they don't feel like,
We're being badgered.
oh, please don't kick me out, please actually do
Yeah.
that.
Yeah.
Please don't."
Sean was really bad at that.
Yeah, they are.
Yeah.
So-
they don't do shit.
Part of what I'm trying to do, and I love feedback from everyone here, is when I do trainings, is try to get people with lived experience to be part of that, so they can speak to their own personal stories. So like, we're putting on an 8.5 hour training in Appleton in May, and so I've invited some people to speak with lived experience to help. Like, I don't know, there's some implicit bias.
I'm sorry, I was just saying,
Please speak up.
how long has, like, all these studies and stuff like that, how long have they been going on to decrease the deaths and stuff like that? Because if some of that the stigma could be to the fact that they think that nobody's gonna recover.
Yeah, so how long have people been tracked? I don't know the answer. Most studies are short-term because it's hard to track people long-term. So most studies, the initial studies to approve these medications were, months to up to a year. And some studies have been much shorter than that. I don't know if that plays a
In the
role.
medical community, as they start using more of these kind of medications and see more positive results, will that stigma slow down a little bit? Or?
I think so. I think people are really scared of treatment, and I don't know. Yeah, I think people are really scared of treating, and then they start treating, and then either they have a good experience or they have a bad experience. And it, a lot of people are pretty early in their recovery when they're coming in, and then people feel like they get burned, and it's like, oh no, like that's expected. Like people, if everything was together, then they would be the rare person who doesn't have a heroin use disorder, right? If it wasn't affecting their life, it wouldn't be a use disorder. But it's that, like, you lost all the other supports, and then you're like, well, they never showed up for me again, so, well, clearly this is it. I'm sorry, that wasn't a fully formed thought. But yes, I think that stigma is huge. I think that making sure that we're incorporating people with lived experience into what we're doing is a really important part of overcoming stigma. It's we have the peer recovery coaches from Apricity who come out to our clinic and help people. Sorry, I just saw the baby. I knew the baby was there, but and so just like having people have time with, knowing that people recover, I think is really important, and I don't think people realize that. I'm going to stop myself from telling a story about a interaction that I had with the Lithacka County jail staff. Because, but there's...
The doctor here?
I think also just like advocate for yourself too. Like, you shouldn't have left the ED without being told what your x-rays are. So it's okay to be like, no, I'm just behaving like any other patient. And yeah, sometimes that raises, but like just reminding. What I was going to say about implicit bias, though, right? So there's some of the literature on implicit bias says that how do we overcome implicit biases? We all have it, and part of that is grounding. So you take whatever category that is that sets people off, and you find someone that you respect in that category of people. And instead of thinking about like drug addicts as a whole, you think about this person I know who has an opioid use disorder, and you ground on that person. And so you're thinking about an individual and not a class of people. And that's a really powerful thing. And building that, like, yes, you do know someone that you respect who has an opioid use disorder is part of that. And I think part of that for medical personnel too. Because of this interaction between use and incarceration, and then people who are incarcerated have an almost impossible time finding jobs in the medical field, even though it's like 10% of the economy or 15% of the economy, that really reduces the exposure that people have in their professional lives to people with use disorder, and it's dangerous. First, from the stigma side.
We're probably all dying to know what the county jail said about
Right.
MAT.
The gist of it was that, people who have a use disorder, society should move on.
I
Yeah.
can see that, the way I was treated when I was withdrawing there, or they just don't give a fuck.
And like, aren't you supposed to be here for the community? But I'll leave it there because people's attitudes can change. And so it's really important to keep trying. Yep. And one of the things that I have the privilege of as being a physician in the community is coming into those interactions with some standing. So, okay, well, thank you all for your time.
All right, thank you. All right, let's just take a 10-minute break and then we'll come back in 10 minutes.
Only the driver's doors unlocked.
Thank you very, very much.
Yeah.
How old are you? You're little. 3 months? 3 months. Yeah.
She's just a little bit older than mine, I do.
Yeah, we've got 2 babies in class. We're ending stigma
Oh,
free.
she looked to the left side there.
I better go quick and take her photos.
Okay.
That's a recovery baby.
What if that don't fall in love? And it affected just as much?
So benzos are more similar to alcohol. So benzos affect the same receptor that alcohol does, the GABA receptor. And withdrawal is the most dangerous thing. So we didn't really talk about that, and then get some sensitive about alcohol withdrawal, but so benzo withdrawal can be really threatening, not as often as alcohol withdrawal.
So what about blockers too? They're
So they're not really,
those too?
they're honors. We don't have good medications for benzo use.
Didn't they stop using the benzo blocker because people were like
Because it
seizing?
causes, yeah, because
Yeah.
you don't want to, yeah. So there are still some people who use it, but my training was you never use it.
Even when I was in EMS, that was a thing we could use on the ambulance.
Yep.
And like then, so then 10 years later, as I look back, I'm like, oh my gosh, we could have definitely killed people. Because I had the rebound effect from somebody just using Narcan, who's not pleased that I just took away their last $20.
They're
and they
nice,
just-
they're
And
good times.
he was strong.
Yeah, never underestimate their power.
But, opioid withdrawal is rarely worth it. So unless someone is medically fragile and, has so much diarrhea that they're like a result of potassium, but it's very unlikely. But alcohol is the opposite. So, intoxication doesn't kill many people. Withdrawal can. and of course.
Is there a lot of mixing of both with, like, where people mixing both heavy drug use and heavy alcohol?
You had mentioned during this, which one would you,
I think for me, it was.
you would treat
I use
alcohol?
drugs because I thought.
Yeah.
My sister's a really bad alcoholic and she's really trying
Prescription.
to quit.
So let me
She's
just
had
pull that
to-
up.
So I can
Having a
rationalize.
rough time.
And I'm sorry, I just went longer. I was going to talk about alcohol too, but
that I'm going to.
it's a lot.
And getting all this.
And it's so hard for my sister. She was an addict too, but
Uh-huh.
now her biggest thing is alcohol. She drinks every day from morning till noon.
Yeah.
Until
But the thing is
I realized.
it's harder for her to quit because it's at every gas station. It's at every
It's so
store.
socially acceptable in this
Have you ever heard of
state to have
Yeah.
alcohol. So this is, I'll just pull this up. So, you know, this is, you know, the dangerous thing. The real big difference is that alcohol withdrawal can be deadly. So when someone walks into my office and says, I'm struggling with alcohol, it's like, first of all, like, is it safe for you not to be in the hospital when you're doing this?
Okay.
And, oh, nope.
Because you don't want.
So
you
some
don't
people
want to
should be
think about
in the hospital when they're withdrawing.
How
what's going
long
on
usually?
inside.
Let's see, my
Usually
son.
it's like 3 or
Just by
4
sitting
days.
Think about it.
And-
This is the hardest thing. My
It's
sister
funny.
has a disabled child. He's autistic, nonverbal. I mean, I can watch him. I'm not a problem, but
That's
she
what I
is.
think.
She's so scared to take this leap, but she knows she has a problem.
Yeah.
She's meeting with an AODA person next week here in Wapaka.
Aspect,
but-
because it's not.
Her drinking, she has pink. She went to the hospital a month ago for pancreatitis, whatever it is. It was so painful, and she's gonna die if she doesn't quit.
Focus on.
You know, and I'm trying to get her help, but
Yeah.
she's my sister. It's a little bit harder, so. And she lives in Wapaka County here, so I'm just trying to point her
Like
the right people.
The perfect thing, you know, that I think you look good, right? So like if people aren't, can't for whatever reason,
I think we all.
withdraw in the hospital, and not everyone needs to. So like cutting back slowly and outpatient treatment of alcohol withdrawal work. It requires a lot of commitment
Oh,
because, and which is fine. Like
Yeah.
it works for a lot of people. And so when I'm seeing someone, I'm telling them like cut back by 1 shot a day or less.
Okay. Okay, yeah, like she's trying, like, instead of waking up in the morning, she'll have a cup of coffee instead of a drink like she normally does. And so she's like 10 o'clock in the
So-
morning, and I told her, so every week, like, cut an
Yeah.
hour out of that,
Yeah.
you know?
Or measuring out, like I have people who are like, okay, I'm drinking illegal right now. You know, that's 20 shots or 20,
Yeah, whatever.
something like that.
Uh-huh.
So I'm gonna draw a line on this. I'm gonna start measuring out exactly how much I'm drinking, and then I'm gonna cut that down.
Yeah, like, she used to buy the big bottles, now she's buying small
So
bottles.
those are all good things, and then the.
Do you have any availability to take in patients? Can I tell my sister about you?
I mean, do I really have availability? No, because I'm trying to do all this, but yeah.
But
of
it's
course.
hard for her to talk to doctors about this stuff because nobody wants to listen. And, you know, like, they just say quit. You know?
Which isn't helpful.
No.
Have you ever thought about stopping?
Yeah.
joking.
No, I don't think of that every
No,
day.
I don't think about this. That's like, I don't know. I get that, like, when people come in and, you know, they're 70 years old, and they're smoking. And I'm like, how insulting is it to tell someone who's 70, have you ever thought about quitting smoking? Like,
Right.
It's just nonsense. Oh, what I was going to show, I was going to pull up the, so medications for maintenance treatment on alcohol, so naltrexone is really, really effective.
Okay.
And the effectiveness here, like, okay, it's like not good, it's like,
That's what I went for.
but it's like, much more effective than sugar pills.
Okay.
And so when I'm treating someone for alcohol, like, I really think like, these kinds of medication. Whereas usually,
Or like I said, my sister's seeing someone next week, Wendy from AODA, so.
Acamprosate is like the next. So what I usually use is naltrexone plus gabapentin. Is my usual combination. Acamprosate is not as effective as naltrexone. doesn't seem to be as effective as gabapentin either.
Just
So the studies were like,
She's
some of them started to work and some of them didn't.
Yeah.
So, I used the combination, naltrexone and gabapentin.
Does this just block the urge to drink, or how do these medications work?
I don't know what it is. It's naltrexone.
See, you can use, I never even I know, that's the biggest problem with my sister. She said she was an addict before she was an alcoholic. So like, she's always like,
So sometimes it's like it's all
yeah.
Go from being a really bad alcoholic to being a really bad pothead, or have really bad sort of. Yeah, it's still not the best thing for them. They might get COPD, they might get in their progress. But is it still better than their alcohol?
Yeah.
And so
That's not fair.
yeah.
But monitor both of you guys.
Monitor closely, and the combination of naltrexone and gabapentin.
I was-
Yeah, 'cause I still have to get the
It's
damage.
supposed to be,
This one? The M one?
yeah, naltrexone.
And something happens to
Because
her,
gabapentin is
Oh, okay, okay.
because it activates that same receptor that alcohol does.
Yeah.
So when you're withdrawing from it, alcohol systems are messed up.
Yeah,
It's
like-
just trembling.
Yeah,
like,
bored out of her
you're
mind.
seeing things.
Yeah.
Like gabapentin can help bring that down a little bit.
Oh my goodness, it's turning purple.
Also, some help pregnancy.
What's going on?
So I like using it when people end up stopping that part. That's fine.
Sunday night service.
Do you wanna come out? Okay, come on.
You're booked out.
Okay, ready, set, go, come on. Come on.
Maybe I'll see if she can.
See if she's interested.
Which clinic?
I don't think that we feel it.
Okay, to Karen Wopeka. I think that's where her doctor is, but I don't know who her actual doctor is. So I'll ask her when I get home, and then I'll just have her call, and maybe she can just talk to somebody in your office, like.
Aaron has my contact.
Actually, I think I wrote it all
Michael has my
down.
contact information. Yeah.
Is it all this one?
Yep, no, you can call me, you can send me an email.
Okay.
You know,
I mean, my sister's there. She's ready. She's scared though. She's scared, you know, and she's scared of withdrawal, you know. Yeah. And that's the thing. Nobody will listen to her, and she's like, "Well, I think I might need to stay in a hospital for like a week," you know. And I said, "Yeah, I got a chance. Not a big deal, you know."
Yeah, there's hospitals that do detox and then treatment, or that's just garages before.
Yeah, she won't be able to do in treatment, but she needs to do something. Because like I said, about a month ago she went to the hospital and and she said it was so fucking painful. She quit for a couple of days, but she's back to drinking every day again. And I don't want her to die. I need my sister.
No, absolutely.
You know,
These are life-threatening conditions,
Yeah.
so
How many people go home from?
I wish we had a better, like, referral system, and
I just wish all hospitals
They send me home and
with
said I
doctors
have
would be
no
like
reason
you.
to
I hate going into here. I have so many health problems. I have Crohn's and stuff. So now that I'm marked as an addict, when I have my Crohn's flare up, they won't give me any IV pain meds, nothing, and I have to sit there and suffer through it. Before, they were quick to give me Dilaudid, you know, send me home with maybe 10 Vicodin, you know, but now that I'm marked as an addict, no, you have to suffer through this, and it sucks.
they're worried about.
Until some addict came and did your room.
But if it's moderated, like, okay, you're giving it to me in the hospital, so I can't get more of it, and then second of all, send me home with 10 pills just to get me over this pain feeling, and then let me see my doctor, you know what I mean? I feel like you can tell an addict's behavior versus somebody who's in recovery, you know, when you go into the ER, because I know addicts that just go there to try, you know what I mean? Not everybody's like that.
I got a license. Cash the entrance and off to the right.
Thank you for everything.
Thank you.
Yep.